You know that he has motivated, challenged, and inspired us for years. And it is truly my honor this morning to introduce Dr. Berwick to you. As you know, Dr. Berwick is President Emeritus and Senior Fellow at the Institute for Healthcare Improvement. He's also the former Administrator of the Center for Medicare and Medicaid Services. He's a pediatrician by background. He served on the faculty of Harvard Medical School and the Harvard School of Public Health and the staff of Boston Children's Hospital, as well as Massachusetts General Hospital and Brigham and Women's Hospital. He also served as the Vice Chair of the U.S. Preventive Services Task Force, the first independent member, American Hospital Association Board of Trustees, and Chair of the National Advisory Council of the Agency for Healthcare Research and Quality. He served 2 terms on the Institute of Medicine's Governing Council, was a member of the IOM's Global Health Board, and served on President Clinton's Advisory Commission on Consumer Protection and Quality in the Healthcare Industry. Recognized as a leading authority on healthcare quality and improvement, Dr. Berwick has received numerous awards for his contributions. In 2005, he was appointed Honorary Knight Commander of the British Empire by Her Majesty Queen Elizabeth II in recognition of his work with the British National Health Service. Dr. Berwick is the author or co-author of over 160 scientific articles and 6 books. He currently serves as a lecturer in the Department of Healthcare Policy at Harvard Medical School. We all know him for these things, but we also know him for being a tremendous physician and a wonderful human being. It's truly my honor to introduce you, Doc.
Well, thank you so much for the chance to join you. I wish I could be there in person. It's always a pleasure to visit your part of the country, and I wish that I could have fit that in, but I'm very grateful for your flexibility and letting me join you this way. I'm going to make some pretty brief introductory comments, and then I hope we'll have a lot of dialogue back and forth, and I look forward to that. So first, let me just give you congratulations. Your part of the United States, the Pacific Northwest, has been one of the real leaders for decades now in the quality movement that occupies me. You have a strong history of leading innovations and working collaboratively. You've worked with the Institute for Healthcare Improvement, where I sit right now as a senior fellow, and your efforts to join in on the quality movement have been second to none. It's a stunningly important area. Overall, we've seen progress in the United States and globally on quality, and that progress we should take credit for it. I think that the awareness of the fact that we have severe gaps between what we do for our communities and what we could do for them, it's pretty widespread now, and we have a lot of specific examples of breakthroughs on specific aims and localities. Most famously, maybe work against hospital infections, CLABSIs, and urinary tract infections, and so on. So we have a lot to accomplish. We've accomplished a lot, but the gap is still phenomenal. Phenomenally large. 2018 was an interesting year. In that year, for reasons that aren't quite clear to me, 3 independent groups separately issued reports on the state of quality globally. One was a wonderful report written by the World Bank, OECD, and the World Health Organization together on global healthcare quality in the era of universal health coverage. There was a second report sponsored by The Lancet. It was called the Lancet Commission on High Quality Healthcare in the SDG era, the Sustainable Development Goals era. And then I had the honor to co-chair with Dr. Sanya Nishtar from Pakistan, a committee of the National Academy of Sciences, Engineering, and Medicine, which in September of 2018 issued a report on crossing the global quality chasm. These reports in 2018 represented, I think, a kind of deep breath globally. 3 reports independently arrived at very consistent conclusions, which is at a global scale, the quality chasm, the gap between what we do for our communities and what we could do for them, is still absolutely enormous. The numbers were staggering, even for someone like me who thought I knew the deal. All 3 reports made estimates of the size of quality costs in low and middle income countries. and arrived independently at similar estimates of the number of lives lost globally in low and middle income countries only to quality problems. The number was between 5 and 8 million deaths a year. This is from care failures, safety problems, failures of execution, failures to adhere to evidence-based practice. 5 to 8 million deaths a year. That's more deaths than AIDS, TB, and malaria combined in the world. So quality remains a mountain to climb. And it's true in the United States as well. Although there had been progress, including in the Pacific Northwest, reports with gravitas continue to indicate that we've not crossed the chasm. So good that we're aware, good that we have pockets of excellence. Yet to do is to bring the promise of excellence to full scale. When I think about the work of the Foundation for Healthcare Quality, that's where you fit in for me. You are one of the really bright spots in the country, able to think about bringing quality to scale. Now, how do we do that? You have the secret. I think the foundations you've laid in your region for collaborative improvement work is as good an answer as I can come up with. By building the kind of affection and relationships that you have done in the past and now promise to do even more in the steps ahead, I think you're on the best possible pathway I can think of for bringing improvement to very large scale. The barriers to this scaling of good news are very severe, and you know them. I'm sure you're struggling with them in that room. I'll list a few. The first in Dr. W. Edwards Deming's work, and I think in the current scene, is what Deming called constancy of purpose. Something like patient safety, where we prevent central line infections. It's not a tick the box enterprise. It's not like been there, done that, next problem. The improvement of care is a continuous and never-ending journey, just like maybe maintaining proper finances. We don't say when we do our budgets in organizations, been there, done that, tick the box. We know the job of maintaining organizational financial vitality is just never ending. It's in the nature of the place. The same is true for improvement. It's only successful at scale and for the long run if it is for the long run, which means it has to be embedded in the strategic intent of organizations for the long haul. That's barrier number one. I watch the impatience of too many organizations who deal with quality and then they get distracted by something else. Today it's quality, tomorrow it's, I don't know, it's the pricing problems we've got, or the movement toward value-based care. How are we going to adjust? How are we going to raise the money for the new building? I think there has been a loss of traction. I think that whereas a decade ago, probably if you asked chief executives for the top 5 things on their mind, they would have put improvement somewhere on that list. Today, I'm not sure that's true. So maintaining constancy of purpose is key. Second is the whole idea of generalization of quality, and let's take patient safety as a relevant quality, to a systemic property. The tendency still exists to think of, let's say, patient safety as a list of projects which one deals with as project by project. Yes, that's important. Yes, we should be happy that we can prevent CLABSIs or CAUDIs or perfect opioid treatment in emergency departments. But the whole idea here, the long haul, is to make improvement a systemic property of organizations and systems, never ending, constant, in which the task list, the project list may migrate, but the competency is there as a general property. The third problem is financial alignment. We still don't seem to have a finance system which grips the attention of corporate stewards, boards of trustees, finance officers, executives, to quality as the mechanism for financial survival. And that's because it is not the mechanism of financial survival under some payment schemes, and we're still trapped right now. I think that's going to change. A final barrier is the barrier of mechanisms of spread. That's what makes the work of the Foundation for Healthcare Quality so crucial. You're in the room together. You have a chance to actually learn and work together, but the mechanisms for spread are still frail. In this quest, of course, one thinks about national policy, what's happening with Medicare and Medicaid, or CMS's leadership, or HRSA, and that counts. I mean, I did lead Medicare and Medicaid, and it was a stunningly interesting enterprise and probably the highlight of my professional career. But national action, to me, isn't necessarily where the answers lie. Certainly under the current administration, which I won't get going on unless you ask me, but I become in my as I age much more interested in regional and local activities, clusters of action, like those of you in the room today, a cluster large enough to recruit substantial resources, but small enough to build relationships. And that idea of relationship-based improvement is now central to the way I see the possibilities for now and the future. Healthcare in our country, anyway, is trapped in transactions. We're trapped in thinking about the payment mechanism or the kind of blunt tools we use in policy and finance to send signals or to change the game. I don't think improvement is transactional. I think it's relationship. It's relational. It's knowing each other, caring for each other, trusting each other, building mechanisms for helping each other, solidarity as a feature of a community that I will bet on now in the next era of improvement. Progress, I'm saying, isn't. I just don't think it's going to happen from outside in pressures. I guess the migration to value-based payments is a good idea. Volume-based payments not a good idea, but that's outside in. That's very blunt, and there are all sorts of ways to react to payment for value, some of which will help, some of which will not. What really helps is intrinsic motivation and trusting intrinsic motivation. It's our intentions that matter. That was the big secret behind the 100,000 Lives campaign of the Institute for Healthcare Improvement. It was an unbelievable experience to declare a goal that was pretty ambitious, maybe psychotic, to set out the changes that were needed, the six changes, the six aims in the 100,000 Lives campaign, and then to act with no power, no authority, no payment, only by invitation, only by saying to the world, hey, would you guys like to work on central line infections or heart attack care or avoiding pressure ulcers? The response was overwhelmingly positive. Thousands of hospitals, tens of thousands of clinicians and staff members, technicians showing up to get involved in that campaign. It was a highlight of the work of IHI and its entire existence. There was no requirement, no incentive, no power. It was only invitation, and the only fuel for that engine was intrinsic motivation, that we would love to do this together. Now, you've taken some wise steps as I read the next plans for the foundation. One is to focus. Despite my earlier comment that we don't want to treat quality as a list of things, it is important to have foci so you can cut your teeth. You can experience success. So whether it's on opioid use or any of the other collaborative projects you picked, I commend you. Go for it, but go for it with a consciousness that you're trying to build a systemic property, not just a list of achievements won. Local action, like you're trying to undertake, regional action, like you're trying to undertake, it faces some recurrent problems, and we've seen regional efforts stutter and stall over and over again. And I guess I'll give you a heads up on some of the barriers you meet when you try to work on collaboratives, as you have done so well already in the work of the foundation. One is just to have a common table. We're so busy, we're so distracted by day-to-day demands to just to do what you're doing today, to come together, to be together, which is essential to relationship building. It feels like waste, or we don't have the time or the money for it. And sometimes we don't. And it takes a host. It takes somebody who says, hey, let's get together. Here's some pizza. And I think that that's one of the beauties of the foundation. It is a trustworthy host. When the common table disappears, when through leadership transitions or resource constraints, the effort deteriorates. You need space and time to meet. Time's the other thing, is getting together matters. I think you can do a lot of your work virtually. I know you will, but you have to also see each other, and that time to get together is a crucial obstacle. Continuity of leadership matters. One of W. Edwards Deming's deadly diseases in his studies of quality was turnover at the top. And when I've seen in these regional local activities, when the leadership changes, the air goes out of the tire, and you need to plan for succession. You need to plan for ongoing stewardship of the effort that represents your meeting in the room today. Another is credit. You know, we are in a society which seems to be convinced that in order for someone to win, someone else has to lose. It's not true. I have 7 grandkids. The second oldest is named Caleb. Caleb is a wonderful soccer player. He's actually very good at it and loves the game. And this weekend, my wife and I were taking care of him, or last weekend, and you know, Caleb had a soccer game that afternoon, and my wife said to him, you know, how'd it go? You know, how did you do? And Caleb's answer was really interesting to me. He said, I got an assist. And it was really evident from the brightness in his eyes that he was as excited about having gotten an assist as he would have been by scoring a goal. That credit for assists is I think it's a culture we need to build where you feel good about helping someone, not feel good about beating someone. All of this relates to constancy of vision, to the long-term focus. There is also a problem of resource management. Everyone in this room, in your room, is dealing with resource constraints. That's fundamental to the world you live in. And so what you've learned to do is to husband your own, to keep your ring fence what you have. All too much. And here I turn to the work of the Nobel Prize-winning economist, the first woman ever to win the Nobel Prize in economics, Professor Elinor Ostrom from the University of Indiana. Professor Ostrom won the prize for her work on what she called managing the commons. And some of you in the room have heard me talk about this before, but I'll mention it again. What Ostrom was doing was analyzing what Garrett Hardin, the demographer in the late 1970s, I think, wrote about as the tragedy of the commons. The analysis is of a common, what Ostrom calls a common pool resource. It could be a pasture that is in the center of town in the commons. It could be a fishery when in a community that fishes as an industry. It's a common pool resource. Anyone can get access to it, but it's limited and it's exhaustible. To take out too many fish and there'll be no fish. Put too many sheep on the commons and there'll be no grass. What Garrett Hardin wrote about was this tragedy, in that the rational thing to do when resources are limited is get your sheep on the grass as fast as you can, fish as hard as you can. And for every individual, what's rational is to take what you can. That's normal, rational. And it is bound to destroy the commons. Everyone adds sheep, too many sheep. Everyone takes fish, too many fish. And that's why Hardin called it the tragedy of the commons. We in healthcare, we're managing a commons. It's the common pool resource of the public finance, the private finance, the will of the workforce that we all draw on to do our work. When we each take our piece, when we each put our sheep on the commons, we exhaust it. And we learn to compete. Ostrom was interested in communities that succeeded in managing the commons, even though the dynamics of Hardin's tragedy would apply. And she found many, many, many communities that had a common pool resource and wisely managed the resource. And she wrote in her work, and in her wonderful book, Managing the Commons, some learnings about common features of these communities successfully manage scarcity, shared scarcity. I don't have time, nor is my memory good enough to go over all of her elements. There were 8 properties she found they all had in common, but they generally had in common this idea of an explicitness. They understood that they were co-managing a common pool, that resource was limited, that it's exhaustible, and they had a way to hold each other accountable for not being defectors, not just taking all the fish you can. They could create local rules of behavior. They created culture of conservation of the integrity of the shared trust. That's what you have in that room. In that room, you have the capacity to be successful managers of a commons that around our nation is all too much being depleted. The last obstacle to regional action that occurs to me is misunderstanding of the value of failure. Well, when you do the collaboratives you're engaged in, it won't work a lot of the time. Good, that's how you learn. You're going to the edge, so things don't work. And developing a culture in which you share your failures, you learn to treat failure as a part of this, as a servant of learning, is crucial. To do all of the above, the other challenge for you as collaboratives is to change the psychology of measurement. When the theory of excellence is exhortation or judgment or incentive or hierarchy or command, measurement is just a threat. The last thing you want is transparency. The last thing you want is to be measured. All measure can only cause you anguish. And because there's random properties to measurement, it can even cause you random anguish. And so we've learned in healthcare to beat the measure, to game it, to lament it, to apologize for it, to explain it, not to use it. In the world of collaboratives that you're fostering through the foundation, measurement needs to become your friend, needs to become something that is the front door to curiosity. It's the engine of learning, and it is welcomed. And gaming or blaming or misunderstanding or even incenting is just simply not part of the game. It's stupid. What matters is how can we turn the lights on so we can learn all together? That's a culture change, and it's something that I know you can accomplish. The role of data in your work should be local, open, unmasked, not anonymized, trusted, valued, celebrated, not feared. What should you measure? You should measure what matters. You have a number of collaboratives that are underway that are going to do great work. Keep the question alive. How are we doing? That's all you want to know. How are you doing? For your formula for success, you don't need my advice. You've already had successes, but to me, the key is going to be solidarity. It's going to be a key idea that you see yourselves as all in it together, part of the same system, part of the same custody of social resources, part of the same enterprise of shared learning, and you enjoy it. Enjoy being together, not apart. At a rather vicious time in our nation when separateness and differences and antagonisms are being emphasized, it's even more important that at a regional level, at least you can preserve this idea that we are all in this together. We value solidarity over fragmentation. We value cooperation over competition. We value winning together instead of winning over each other. I think I'll stop there, John, Vicky. I appreciate the chance to have ranted on a bit, and I hope we have the mechanism set up where I can hear questions and we can have a bit of dialogue. Thanks a lot.
Arman, did you have the first question?
Yeah, I've got the first question.
Wonderful.
So I'm just going to come here so maybe Dr. Berwick can see who the question is coming from. Dr. Berwick, thank you for your wisdom. This is exactly what we were looking for, and you hit all the points that we were desiring to hear. And you are the man. You've done this work and become the leader in this area to how to do the work. One of the qualities of foundation is that we are grassroots work. We are the physicians and frontline staff doing the implementation. So from the learnings, we translate that immediately to our hospitals. People participate in our boards and meetings are usually the leaders of their hospital. So this is our unique opportunity. Our foundation programs voluntary to participate, and the hospitals actually pay money to become part of it. And that limits us to reach out the whole souls of the Washington state population. So we have some limitations and in that regard. But this opioid initiative that we now call it Moving the Needle campaign is so important. We want to reach out to everybody. And my question to you is specifically, if we were going to do that, and after your talk, there will be 3 panels from the regulators, from our representative Cody here today, and then we have payers, and we have participating hospitals panel. What message would you give them to get this community effort going forward, and what tactics we need to use to make this available to everybody in the state? Thank you.
Thanks, Arman. Well, first, I'm so excited about the Moving the Needle campaign. This country needs some breakthroughs. We need to be able to point to some geographies and communities that have beat this horrible opioid epidemic. And I think that, you know, my hopes are, I think that you stand a chance of setting in place an example that everyone can turn to and say, oh, look, it can be done. So I couldn't be happier. And your earlier point about this being, in a way, grassroots, that the physicians and nurses and clinicians themselves are participating and leading, is so important. What happens in the world of healthcare policy, including with opioids, is the policy making and financing apparatus gets disconnected. It gets unplugged from the facts on the ground, from the work of the work that's really going on. You know, one of the most important themes in modern approaches to improvement, the Japanese methods that we've learned from, is go to the gemba. Gemba is the shop floor. And if you want to be a leader of improvement, you've got to be on the floor. You've got to be where the work is going on and know and be with, even love the workers. And in this separation of policy and finance from the gemba is exceedingly costly. And we can go into that more anytime if you want. Now, my advice to you, as with these panels, as you're getting together, is use the glue. That is, understand that you are all part of a system larger than any one of you. The glue is the mission. So committing all together for real, to achieve something together that none of you can achieve separately is absolutely essential. It's the only thing that will bond you. The mechanisms won't, the doctrine won't, the mission will, the purpose will. So table by table, group by group, own the purpose, own the mission. And that, by the way, is going to involve owning some measurements. The measurement in the world of improvement is not used to drive improvement. It's used to support improvement. And so curiosity, you know, what would you all like, table by table, community by group, sector by sector, what would you like to know together that will tell you if you're making progress? What's the information you want? By the way, commit to short cycle information. It's the ticker on your desk every morning that's going to matter, not the annual report or the 6-month summary. Can you set up all together a way to know about the work you're doing, the progress you're making, literally every morning? That's not a metaphor, that's an assignment. And so I would say, panel by panel, can you together agree on what's going to appear on each of your desks every morning that will help guide you toward progress? Another thing is learning. You can't get it right the first time. It isn't going to happen. The opioid epidemic is too difficult. And so can you as stakeholder groups, and then all together as a collaborative, set up a mechanism for very frequent and rapid reflection where you're saying, how did it go on Tuesday? What did we learn last week? Where are we now? So that you're kind of navigating together through these thicket toward results and goals that you've agreed to try to achieve together. You have to be a learning system. That means putting energy into it. I'm very glad you're together today. I'm very glad you're going to have the panels. They're going to be helpful. But my question is, when is your panel going to meet next? And if you say we're going to get together in 6 months, it's not going to work. The answer has to be tomorrow, and then the day after, and then the day after. Can you set up a tempo of collaborative reflection and dialogue that actually matches the urgency of the problem and the pace of learning you could establish? And two final thoughts. One is, get the patient in the room. Get the people in the room. The people with a lived experience of opioids will be your best members. The people who day to day are struggling in their families with whatever is driving this epidemic will be your best advisors, your best participants. it's not talking about focus groups or tokenism. I'm talking about literally setting up your empanelment so that people with the lived experience of opioids are with you every single day as you try to beat this terrible problem and move the needle. I think that the hardest thing you may find is the first thing I mentioned in my recitation of the obstacles to regional local action. That is a persistent common table. So how can you possibly set up a reflective structure in which all of those panelists that you just mentioned to me, Arman, are together in a very regularized way, learning, exploring, and learning about their interdependencies? The most valuable question anyone on any one of the panels you're about to have can ask now and throughout the entire duration of the Moving the Needle program is, how can I help you? Not, here's what I do, not let me present my slides, but how can I help you? Where everybody's asking everybody else that question, then you have the potential for systemic work.
I have one, sir. Rob Rush. You had mentioned and you elaborated somewhat about using measurement to support improvement rather than to drive improvement, and you mentioned those drivers in very good form. Can you be more? Our hospitals are constantly using measurement as seeming like a driver, and I can't get them off of that to a common theme that we can go with, such as moving the needle. That's a common thing that us in this forum can grasp onto, but it's tough because we're often looked at these things as transactional things, like we're being paid to make a bonus to make a certain like length of stay thing or a metric. Can you elaborate a little bit on that support versus drive for improvement? Thanks.
Sure. First, let me say in the New York Times yesterday, what's today, Tuesday, no, the day before yesterday, Sunday, there was an op-ed by a columnist, a physician columnist whose name is escaping me. I think her name is Danielle Ifra or something like that, which addresses this issue of relationship between the medical staffs and the hospitals around intrinsic motivation. I urge everyone in this room, including the hospital leaders, to read that wonderful column. Yeah, well, let me elaborate. So in the world of improvement, let's say moving the needle, dealing with the opioid epidemic, when you're in the healthy mode, when you're actually doing the work properly, hospitals and you all together will be trying stuff out. You'll be saying, I'll give you, for example, there's a very good research effort underway now at Johns Hopkins, led by Josh Sarfstein, on processes in emergency departments that can basically initiate treatment for people being treated with overdoses instantly. And Josh is pretty convinced that this kind of instant connection could be a very powerful tool for getting people into help. With an emergency room is actually operating as a detector apparatus and taking action instead of just referring. So that would be a change concept. I think it's a good one. So you physicians, nurses in the room, we're working with your hospital, say, let's try it. So you're going to try it. I hope some of you will try it. So when you try something out like that, it's going to be hard. There are going to be some fumbles, but a few of you are going to get going and do it. And then you need to have to say, well, did that work? How did it go? And if you're really excited about moving the needle and the activity is local, you're going to want to have that answer as fast as you possibly can. You're going to want a measurement. You're going to want to have, it's an answer to a question, which is, how did that go? That's the dynamic of improvement. When the measurements are top down, they're kind of this used to motivate. It doesn't work. It's a misunderstanding. The motivation has nothing to do with the measurement. The measurement's a response to the motivation. And it's an answer to a question, not the cause of a question. That's the healthy version of improvement. Now, how can you work with the hospitals? I don't really know. They have to be in the room. You have to have this level of conversation with hospital leaders. They will continue to use measurement as drivers. That's too much in the bloodstream, and it's too much what's happening in the policy world. But you can have a deal, an understanding with the hospitals that will want to play ball, that I guess in addition to that, you're going to have a real commitment to this kind of constant answer to the question, how do we just do? One challenging form of that, by the way, is case by case, patient by patient. I know this is like a little too technical into maybe in this day, but it's like you really need to know how Mrs. Jones just did. How did Eric do? How did Ben do? And this instant or agile knowledge of the fate of each individual can be a tremendous resource for improvement. And no payer, no pay for value system is ever going to think at that level. You can and you should, and the hospital should help you do that. So those are some thoughts about it. It's a very tough issue, full of doctrine, by the way. A lot of people would completely disagree with what I just said to you.
Don, this is Hugh Straley. It's always good to see you. It's been many years. So.
How are you doing? It's great to hear you.
I'm good. Wish you were here. The weather's great, and you'd love it. But of all the things that you talked about, data is one of the important issues, and we've talked about that quite a bit. Data is often seen as proprietary by payers. And yet we can do data locally, just collect it in our rapid cycle improvements. But even on a national scheme, what is your thought or vision about how we're going to accumulate data to support improvement, particularly from clinical systems? We have claim systems, and we all know that the claim systems don't help us very much with immediate rapid cycle improvement. And how do we get the clinical system to talk to each other, and how do we break through the proprietary barriers that exist about data? Can you help us with that, Don?
Maybe. I'm not sure, Hugh. By the way, if you follow up with a phone call or email me sometime, I'd love to catch up with you personally.
Yeah.
Yeah, I understand the barriers. I mean, well, let's start with proprietary stuff. I think for, let's say, moving the needle, you leaders in the room, you clinicians need to go to whoever's posing these barriers and just say, stop it. There needs to be a firm position on this one, which is this is toxic. We cannot make progress if data are held in secret and proprietary ways. There needs to be a battle, and I would have it. And I think if you've got the clinicians in the room and you've got the public at your side, I would say just plain stop it. You can't learn if you can't widen the field of vision. And that's going to mean a much more generous view of the use and availability of information and data. Call the question. I would say another way to do it is end run, which is with the help of the foundation, you in the room and you, let's say, involved in the Moving the Needle campaign, you can decide that you're going to create your own channels and set them up in parallel and say, in our world, we share. You know, I had a wonderful experience years ago in IHI. We had a project. It was actually a project on organ transplantation. Variation in harvesting organs for transplantation around the country is vast. I mean, hospital rates of harvest go from 15% of available organs to 85%, among the best performers. And we had a project in which we did that. That was a measurement. Each hospital submitted its information on how many organs it was harvesting, and it was a collaborative. And I remember being in the room, and we put up a scatter plot of the hospitals in rates of organ harvest without names. They were all anonymized. And then I turned to the people in the room and we said, do you want to light up the dots? That was our term, light up the dots, which means wherever you see a dot, there's going to be a name. We can hit this button and we'll light up the dots. And it was unanimous. Everyone in that room said, of course, light up the dots. I want to know who to talk to this morning about who's doing better than me. And then we lit up the dots and never looked back. You need to light up the dots. Some of the obstacles you're going to run into that I'll mention, one is HIPAA and privacy issues. This is a terribly difficult myth. There are all sorts of myths about what HIPAA will let you do and will not let you do. And I would say, as a little part of your project, don't let HIPAA myths stop you. And I can get you referrals to people that will help guide you in that. But we need to get out of that. That's been a very immature part of our reaction. So Hugh, that's some of my reactions. I don't know how full it is, but I urge you to take a real strong leadership position on the importance of transparency. So I'll say one other thing. Some of the measurements that will really matter, by the way, are not the aggregate ones you're thinking of. They're very, very local. And so even while this battle is fought, there's a lot of, if the foundation can help you each set up the local measurement toolkit for moving the needle, simple stuff, very simple stuff, even imperfect stuff, but just good enough to use, that will be a step forward for everybody.
Dr. Berwick, we also have this a little bit of an issue in Washington State, and where some hospitals are part of our database or our project, the SCOPE project or Spine SCOPE project, and some of them are not. Obviously, some have, because of the financial barriers, other mechanisms by which to collect data. But what you just said, set up local measurement toolkits. Well, that can go to anybody.
Yeah. Yes. Was that John? Who just said that?
That was Dr. Rush.
Hey, Dr. Rush. Bob. Yes. One theory, one approach you could take as a culture for the foundation and for the project is anyone can get in. That is, you could have core members who are part of the general data structure, kind of meet the criteria. But I think that an open door and a welcome mat are really good ideas. And people are feeling around healthcare today, like isolated and a little beaten up and unwelcome. And I think you can change that. You can have a culture that says, you want in, of course you can be in, on your terms. I think you'll find lots of will there. And I'd never turn that away. Our mantra in IHI is waste no will. And if someone says, I'd like to help, but I can't do it the way you outlined, you say, okay, come on. How would you like to help?
Peter Dunbar. I'm the CEO of the foundation, which you've made my job more difficult because you've raised the expectations rather high. How do you persuade people to get organizations to actually participate in data sharing? How do you're a very persuasive person, how do you get people to participate? One of the challenges we have is that organizations, they get a lot of priority. And quality is clearly a very high priority, but finding the words to get organizations to come in and share their data is really difficult.
Yeah, I know, Peter. I've got 3 ideas, but I don't have a really certain answer. The first is get the patient in the room. The patient affected by whether or not data are shared is going to be relatively impatient. They're going to read the riot act a bit. They're going to say, "What are you talking about?" My most dramatic experience of this was way back. I was working with the Cystic Fibrosis Foundation, which had about, I think it was like 160 CF centers, and they had a lot of data. There was a research database, but it was all anonymized. They never, Michigan couldn't find out how Ohio was doing. That was not allowed because you didn't know who was Michigan, who was Ohio. And so they began to consider, under pretty bold leadership, turning the lights, turning the dots on. And they were having a lot of trouble with it. And a woman named Honor Page, who I had met at Cincinnati Children's Hospital, was the mother of Laura Page, who was a cystic fibrosis patient. And she was a pretty activist. And so she came to the Cystic Fibrosis Foundation board meeting that I was at. And I said to her, Mrs. Page, the people here are nervous. They're reluctant to share their data. They're afraid it'll induce competition and bad will and deception and defection. What would you like to what would you like to say to these people who are worried? And I remember Honor Page, Mrs. Page, turned to the group in the room and she said, I want you to know that for my daughter, the clock is ticking. And you could have heard a pin drop. And that's the day, I believe, the Cystic Fibrosis Foundation decided to share their data openly. So the patient will tell you what to do. A second idea is to try it. So you go to the reluctant people and say, okay, you don't want to share your data because of A, B, C, and D. Do me a favor. Can we try to share data about one thing? Let's say moving the needle. If it explodes, if you don't like it, if you're embarrassed, if something goes wrong, we will not. Then we'll say it failed. Because data sharing is safe. People just don't realize it. And so if you can set up a way, Peter, to just plead for organizations to try it out, I think you might stand a chance. The other thing to do is to create social pressures. For example, back in that room of hospitals on organ transplant, it was unanimous to light up the dots, but I'm sure there were people in that room that were really scared of that. And what happened was it became the thing to do. You know, there was enough momentum that it was basically, it would have been embarrassing not to. And I think you probably, given the ethos of the foundation, I mean, maybe you could set up social venues where sharing data just becomes the thing we do here. And I would encourage you to think that way. So keep trying. And if you find a better answer, please tell me, because I need to know.
Okay. Dick Whitten.
Thanks, Peter. This is Dick Whitten. You may remember that I'm Senior Medical Director for the Medicare Administrative Contractor, and I give that additional background because I want to draw on your experience. I hope I can continue to see that smile as I ask the question. As the Medicare contractor and watching these activities here in Washington State, I've been extremely frustrated because typically everybody but Medicare is able to participate. And so we help bring things in from the point of view that the extent the contractor can. But just from your perspective, let's talk about the Moving the Needle campaign. I was on one of the panels this morning. But what can we do to help bring in the activities such that Medicare can be a participant and at least not be an impediment to some of these activities? You know where I'm talking, so I just appreciate your perspective. Thanks.
Dick, I absolutely know what you're talking about. In Washington, when I arrived to run CMS, one of my top priorities was transparency and openness with our data. It was really, really hard. Basically what's happened is through the years, a culture of data management developed within Medicare, some of it driven or supported by statute, some of it not, about withholding data, restrictions, sharing, and that culture is really, really dense. I think that we began to make progress. It certainly would have been, had I been able to stay on, as you know, as a recent appointee, and had to leave after 17 months because the Senate did not confirm me. They didn't hold confirmation hearings. I would have pushed hard for that. I think it's a treasure chest that Medicare sits on. So I guess I'm in sympathy with your point. It's going to take leadership. I think it's going to take presidential leadership. I think that this culture of withholding is dense enough that you absolutely would need Oval Office management of a new culture of openness and transparency. The potential gains are phenomenal, and I'd love to unleash you as a contractor to share and help in this effort. I just am not in a position to do that right now, but I think it's a battle well worth fighting. I think one of the only suggestions I would have, Dick, is check the myths. I became convinced at CMS that a lot of the data withholding behaviors were based on myths about what's proper or what's even statutory. And I think a skeptical look at, wait a minute, show me the reg, show me the barrier, because I don't remember that. And I think you may discover that some of the restrictions you wish weren't there aren't there. They're just believed to be there, and maybe you can do something with that.
Dr. Berwick, thank you for your comments. I'm Dan Lessler. I'm with Comagine Health, which is a QIO here in the Pacific Northwest.
Yeah.
And I had a question just going back to your earlier comments, where you made the point about the disconnect between policymakers and people on the ground who might be delivering care or trying to improve care. Actually, we have some policymakers in the room here today. And actually, I would say that Washington State, in my experience, actually is quite progressive and forward-looking at the state level and even at local levels around the work that policymakers do. But I'm curious to know what your thoughts are for policymakers with respect to how they can help promote the kind of atmosphere that you described that successfully leads to quality improvement on the ground. Should they just get out of the way, or is there a policy agenda there, and what does that look like?
Sure, I've got 3 suggestions, and these I was a policymaker, so I think I can say you can walk this talk. Well, maybe it's a 4th suggestion is buy the aim, accept the aim, that you are part of the system. You're not above it, you're in it. And so as a policymaker, the move the needle aim, own it. It's yours too. And the interdependencies I earlier talked about matter too. Remember that question, how can I help? What do you need me to do? That's the question a policymaker needs to bring to the entire team working on moving the needle, and listen. So here are three ideas. Idea 1 is go to the Gemba. Get out of your office. Policymakers should be visiting the very clinical sites that are going to be involved in this and just staying silent or asking questions and listening. When we in CMS did the Partnership for Patients campaign on patient safety, one of the things I'm most grateful for was that Secretary Sebelius, who I have enormous respect for, got on airplanes. I think she made some 12 or 15 visits to hospitals and clinics all over the country who are getting involved with a patient safety effort to ask, how's it going? What can I do? What's it like? Here's why it's important. Tell me about what it's like here. And it was like golden. So get out of your office. A second would be inquire about your own, what you could do. That is, can you, as a policymaker, could you please set up ways for the workforce that's working on the needle, moving the needle, to make requests of you and be open to those requests. When I was a CMS administrator, one of the first things I did was go to the Joint Commission and the AMA and the AHA and ask them to send me what I sometimes call a Valentine. Can you please send me a memorandum of everything we're doing wrong? Just list every single thing you wish we would change. And I got long memos. I mean, I got many suggestions, but I'll tell you, it was absolute gold, because I'd say half of the suggestions were like, what? We're doing that? We need to stop that. It was like a wake-up call. So I think policymakers need to be much more, to be humble and open and get those Valentines. Find out what you're doing that hurts, and what could you do that would help. Listen. And then the third is stop stupid stuff. That if you really would be willing to go to the Gemba, go to the workforce, go to the people moving the needle, and maybe in parallel to what would you like me to do, ask for nominations of stupid stuff, things that you're doing that you probably don't mean to do, you probably inherited or is there for some reason, and it's in the way. And take it seriously. Listen, and don't be defensive. See if you could change it. In the IHI, we have a leadership alliance. It's a group of 40 organizations that meets regularly, and that's one of my jobs is to mentor them. By the way, anybody in the room that would like to join the Leadership Alliance, send me a note, and I'd love to sign you up. Right now there are 40, and we did a project 2 years ago called Breaking the Rules for Better Care. We invited the organizations to ask their patients, families, and staff to nominate stupid rules, things that stood in the way of patient care that people didn't understand why we have that rule. And 24 of the 40 did it. The 24 organizations together came up in 1 week with 360 stupid rules nominated. And what was really mind-blowing to me was 85% of the 360 rules were not laws, they weren't statutes, they weren't regulations. They were just habits or myths or administrative stuff that could be changed. I would urge in the moving the needle stuff, here's a wonderful opportunity, policymakers, go find out what you're doing that you need to stop, or that's no offense, don't. And I've been there, I've done that, and you can do it too. I think those are some ideas.
Good morning. So my question is about what do you see the future look like for healthcare quality leadership, not only in the U.S. but around the world, and what is that responsibility and what does that investment look like? And the second part of this question is how do we build that same kind of infrastructure on the patient side so that we have patients that are actively co-producing health with us? And what would that look like in your opinion?
Well, the patient side I'll start with, it's pretty exciting. I mean, there's a vocabulary around co-production, co-design that is happily taking shape. Certainly the communitarian sense I have in the Pacific Northwest, I see you as different in communitarianism, offers an opportunity to invite that kind of shared design. And I'd say just do it. I mean, there are some great examples around the country of places that are trying to invite patients, families, communities more into design. Cincinnati Children's Hospital Medical Center is a great example. And learning those processes of collaborative design and backing them is good. That's why earlier I said for the Moving the Needles campaign, make sure people with lived experience of addiction are in the room and doing it. They're leading too. They're with you. I think one of the things that happens, by the way, with co-design is cost fall, because patients and families, they know where the waste is. We waste their time, we waste our time, and I think you could help them, and they could help us much more in the cost reduction world. I could say more about that, but I think so in terms of directionality now, I mean, to be honest, I'm worried. I think that we are in a period of distraction by treating healthcare as if it were a financing problem instead of a quality challenge. I believe since the day I began studying Deming's work that the best solution to the quality to the financial dilemmas is to improve quality. But I think that's it's a rarely held theory in healthcare delivery in this country or anywhere in the world. I don't know if we can get out of it easily in this country under the current financing systems. I think the fee-for-service environment, the avarice that we see in a lot of healthcare delivery and supply chain behaviors is really, really in our way. I have been public and been so in favor of a Medicare for all approach. I don't think it's necessary to fall on our swords on that right now, but I'm testifying tomorrow in Congress on that. And I think until we get some kind of consolidated payment scheme, it's very hard to put the resources where they're really needed. And I think that would then energize a quality effort. Two pieces of good news. One is the 3 reports I mentioned from the World Bank, WHO, and OECD, Lancet, and the National Academies on quality. It's woken people up. Dr. Tedros, the head of the World Health Organization, at his speech at the World Health Assembly this year, featured problems of patient safety, especially as an urgent imperative for the world. So there's some waking up globally. I also see some countries where there's some interesting stuff going on. In England, where I go often, a document well worth your study is a challenging one. It came out in January from the National Health Service in England. It's called the Long-Term Plan for the NHS, the Long-Term Plan. It's 130 pages. It's not an easy document, but it lays out an agenda for real progress that involves quality and redesign and happily much more authentic combination of work on acute care and social determinants. So there's good stuff going on, and I guess the optimistic part of me hopes we'll get there. I am sorely distressed at the current federal leadership in this country. It's exceedingly destructive and right now in the way of everything I just said.
Thank you very much, Dr. Berwick. I believe that you have filled our hour with joy. So thank you so much for agreeing to be with us virtually, and look at the carbon footprint you're saving by not coming to Seattle. You're missing lovely weather and the friends you obviously know. So I really want to thank you and give everyone a big round of applause and thank Dr. Berwick for his.
I certainly hope I can join you in person sometime, folks. And thank you for having me.
If you have any final words, I'd be happy to hear them. But I think you summed up good.
Solidarity, stay together. You will get this done together and in no other way. So just